stiff neck or other brand name collar. They don't work any better. Never have, never will. Padding is a key issue as far as seat collars. Make sure there's no little pinch points in your jaw or bony prominences, because they'll end up with tissue erosion in 30 minutes and they get these big ulcers. And they have to heal from that over the next period of months. So I threw a picture in here, well, a bunch of them. These are inappropriate collars. I need to throw my kids in there, and this is the one that's supposed to fit my daughter, and look what she can do with her neck. Come on, this is all wrong, people. Don't think seat collars stop you. And then a wrong size collar, of course, look what she can do with her neck. Don't think these are your saving grace. They're not. The big thing with little kids, they have these big occipits, their heads stick out, so when you package people, like I put them on a backboard, I put a little foam down because I don't want to compromise the back of their head, because they'll get that tissue erosion in the back of their head as well. Pad them, right? And I put my girl on there. Now if you look at her, think where her spine's going, and then it jots up to her neck. So I put a quilt down. I put it 4 layers, and I put it 8 layers, and I'm making it thicker and thicker. Now this one, it's just coming up in a second. Yeah, that one. She's actually laughing, but if you look at her spine, it goes straight into her neck. She has great alignment now, with 8 layers of a quilt underneath her. Now, when you do this in the ER, or you bring the ER, they go nuts. You can't put padding underneath them. You can't do this. I had a girl who I brought in from Jordan now, obvious lower extremity weakness and numbness. Significant C-spine pain from a boating injury. We couldn't get her out of this position. So we padded her in exactly the position we found her in. Got to LDS hospital. I will pick on any hospital who likes to do these kinds of things. Got to LDS. First thing the nurse did says, who put her in this position? She can't be like that. Where's her seat collar? I says, ma'am, she can't move out of that position without causing more deficits and more pain. And of course, we had 2 pillows underneath her to hold her head in that position. She walked around the patient, jerked the pillows right out, and popped right back on the bed. I said, ma'am, you're coming with me. I took her right out to the docks out there, and you don't put pillows underneath people. This is totally inappropriate. Anyway, this is the kind of pushback you get. So you stand your ground. You learn about spinal immobilization, but don't put them on these backboards. You put these little kids on backboards, that's my girl. I mean, she knew what I was doing. She's crying, for heaven's sakes. Put her in a better backboard that's designed for her, though. Okay, now she's fine, right? Plus, it's a little more convincing, a little bribery, but... Vacuum splints, wonderful things. My own crew in Moab, I've just got chewed out for doing this down in Moab. New director of the ER, chewed out the nurses, I said, the EMTs. I said, you put them on the phone right now. They don't know what they're talking about. You do what's right. Don't let people intimidate you, okay? So long boards, short boards, I'm going to cruise to this. You can be creative out there. You can make your own boards out there. Get a bunch of logs. Rip the door off the shed if there ever just went up there ever again, you know? So I didn't encourage that. So. Although I'm sure Steve would probably like us to rip the shack down, so yeah. Long boards, be creative. I'll just get through some of these things. Let's get some fun things. All right, let's go to fractures. Well, wow, time's flying a little too fast. That's just a minor flesh wound. If you like Monty Python, huh? Yeah, so that's his form. It's just bent across his chest. Now, what's the key to this? Now, you've heard me harp on these issues. What's the big problem here? Tenting here and then an open fracture. Don't miss those things, right? So tenting is a huge deal. Tenting means the arm's bent, the ankle's bent, you'll see more of them, but it's stretching the skin and compromising the circulation. So if you see white skin over a broken bone, you've got to reduce it. You have to reduce it. Okay? And it's not all the way necessarily. You get to just reduce it enough to take that tenting down. Otherwise, 20 to 30 minutes of that tenting, this tissue dies. And now they not only have an open fracture to deal with, now they have a quarter size or bigger ulcer that doesn't heal for probably a month and a half to 2 months, or if it's bigger than a quarter, they get a skin graft on it. You don't want to do that to those people, so you need to reduce them. This is true wilderness medicine, what you should be doing. Let's see. So question, do you actually reduce fractures in the field? Yeah, so there's tenting issues. If there's neurovascular compromise, open or closed, be careful about that. You don't want to be sucking the bone back in without washing it really well. But if you leave the bone out, you've got it covered up. We'll talk more about that. Fracture decisions, you see all kinds of fun fractures. I mean, I love fractures. I think they're fun to work with. You know, these aren't huge issues. They look funny, but oh, good grief, walk down the hill. Put them in a funky splint, tell them to get off the hill. That is not an emergency. That's not an emergency unless there's vascular compromise. That's not an emergency. They can walk off the hill if they want to. They don't have to have SAR come carrying them off. So it's not necessary. They sure don't have to fly off the mountain for that. Some of them, you say, well, that's tibia. You're probably not going to go very far on that one. So, yeah, they need to be carried off, and you make the decision if they fly. But it's not a true emergency. He just needs to get off the hill and get his bones fixed. Now, that bone right there, you've got to get it covered. If you let it dry out, we will actually just cut the whole end of that bone off and have to replace it with graft bone. Do not let bone dry out, and do not let tissues dry out. Moist gauze. You don't have to soak it. But if you let it dry, it'll haunt you, and so will the patient. See? Moist gauze. Next thing is never splint somebody up without looking at their wounds. If you look closely at these things and you miss a little ditzel of a cut, that's your tenting right there, so you can see that. You miss a ditzel of a cut, though, and you tell me it's a closed fracture, I don't tend to open them up every time they come see me. I usually say, listen, they said it's a closed fracture, we'll get them to the x-ray. And then I've got a trauma patient over here I have to go see. By the time I get to him and actually unravel it, I find out an hour and a half later it's an open fracture. Bad. Okay? Open fractures go to the OR pretty much every time. They must have antibiotics right away. So do not splint somebody unless you know exactly what's in that extremity or injured part of their body. All right, so as far as splints, it's ugly, fat, and fluffy. That is your rule. And again, like I said, you don't hurt anybody. Otherwise, be super creative. I've literally seen people brought in on doors, all kinds of homemade devices. I think it's cool. I love it. So no rules, just don't hurt the people and don't make it worse. And again, you can go all kinds of things out in the field, whether it's your ice axe or tent poles or life jackets or any device you might happen to have. You can carry your frame apart in your pack. I like my pack, so I'll tear their pack apart, but you can use whatever you want, all right? So again, no rules on that one. Traction splints, that's a whole separate lecture, but lots of fun about things you can do and how you make your own traction splints with a simple stick. If you know about traction splints, to hold it like a femur, use your own boots for heaven's sakes. Right? You don't have to have fancy little devices. All you have to do is take your boot off. You cut a slit in this side, and you cut a slit in this side. Then you take a little piece of webbing, which you're probably going to have up there, you run it through their boot, put their boot back on. Now you have an instant tie-off that fits them perfectly, that doesn't compromise their tissues. So be creative in how you do even traction splints. Right? So again, think through it and practice before you have to get in that position. Good enough. This is don't hurt people. There's all kinds of different things. We'll cruise through it because I'm running way short on time. Thermal traction, lots of things, yeah, okay. There's all kinds of fun devices, but honestly, use what you have on your hand. Don't have to worry about buying fancy things. Learn prosthetic knots. You all should learn a prosthetic knot and how they work. And let's see, traction. Almost done with the thermal traction section. Make sure you pad their groin really well, extremely well. It's the wrong kind of traction device. We'll skip that one. All right, facial fractures. You can see fractures going down through his jaw and through. There's another one that goes up. You can't see really well. You know, there's not an awful lot you get to do about it. Make sure you look at the teeth. Make sure you keep the teeth moist. If there's loose teeth, just sitting there, you got to look back there and take them out so they don't aspirate them or suck them down their throat. Keep the tissues moist, 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 moist. They dry out. It's so hard to fix them. Be careful about blood products. Just like a nosebleed, if they start swallowing your blood, they will eventually throw up. You get anybody here, you get enough blood, I promise you will throw up. So don't lay people down if they got facial injuries unless you must. Remember I said about backboard and seat collars? Most people don't have to be in a backboard and a seat collar. So keep these people sitting up. Let them maintain their airway. Right? Facial area, eyelid injuries. Yeah, significant injuries like that, not much you get to do about it. Just don't push on the eyeball. Keep the tissues moist. Ears, not a big deal. I mean, snip his ear off, getting a haircut was kind of funny, but this thing you don't want to miss, though. And people say, hey, what do you think, team? I did this, I smacked it on a rock last night, and it's getting bigger. That needs to be taken care of right away. Otherwise, they become permanent. If you look at wrestlers, they get these cauliflower ears, what they call them. They're permanent. You don't want to leave blood behind in their ear like that. They have to be drained. This one, you'll see more than you might think. So this child's screaming all of a sudden, was doing fine. The parent said all of a sudden she's screaming and screaming and holding her ears. And what's up? This is a classic one. Yeah, moth flew in her ear. Now, or bugs. But the classic one around here are moths. They love ears. Anything dark can out. Do you know what a moth is like though? Those little wings, they, you touch them, they leave all that debris on you. Well, they fly in, they crawl in, but they get stuck on the wax. But they can't back out because their wings, if they try to back out, do this kind of thing. So they just keep trying to go forward. And they do this kind of thing to your eardrum. Wow. Yeah. Oh, they freak out. It's horrible. Some people get sick and throw up on you. All you have to do is put some oil in there. So I don't care what kind of oil you have. Just don't put anything that burns, but any oil. You even have to have, those of you have your vinyl oil, that works really good. So anyway, something interesting to talk about. Foreign bodies in the nose and the ears, well, you be creative in how you get them out. Take your surgical tubing you should have. You can actually usually put it right on the end of it, snip it off flat, put it over the item, and it works pretty well. Just make sure the parrot does it, because sometimes you get that horrible smell. It's like, oh, that's nasty. You can try different things, but usually if you get something really small, like these little forceps we have, they're nifty, but sometimes, again, you can use these things, but for the average, these are just too big. There's pediatric versions you can slide right past them. We slide it past the foreign body, blow the balloon, pull the whole thing out, and you're done. Just like that. Oh my, we got it. Well, we got 100 more slides if we wanted to do them all. Chest problems, I'm not going to, oh, oops, that's a bad problem. All right, needling the chest. Did I get spit? That was cool. I have to show this one. Will it show? No, come on. No, oh well, it's okay, it's fun. I got a joke out of it. I'll have to show it to you later. Head injuries. All right, the question is, what do you do with head injuries in the wilderness? And you have to make these decisions because I don't want you flying all these people out for minor head bumps. The question is it an open fracture? Okay, they get out. They're gone. If they're completely unconscious and they're still unconscious, yeah, they get flown out. Don't have much choice about that one, or with bad weather, they get to be hiked out. But you look at all the different types of bleeds and problems you get in the brain. The biggest thing for me is asking, what's the critical nature? Are they unconscious? Did they get knocked out? Even if they got knocked out for a few seconds, it's still a little more worrisome. But if they're awake, glassed out 15, meaning they're alert, no appropriate, they're not throwing up, they're not staggering, the meditation's sharp, I don't think that can be flown or even walked out. They can go down with somebody else. But you need to learn the criteria about head injury. That was a real quick summary. But altered mental status that persists, unresponsiveness for over 5 or 10 minutes, those people need to be taken off the hill. Bad headaches, again, neurological deficits, but not everybody who has a head bump has a head injury inside. I think we were way over killing these patients who come and see me in the ER. But some people don't know. And I'd rather see them if they're not sure. But they don't have to be flown off. If there's a question, consult somebody on the phone if you're not sure. Blisters. This is extremely important. Now, it's not so big of a deal on the mountain, but I promise you, you've probably seen people with blisters who cannot get off the hill. Yeah, it's not pleasant. So I would challenge any of you, put a tack upside down in your shoe and step on it, put your shoe back on, and walk around the room 2 or 3 times. You're not going to do it. Your body will not let you do it. Physiologically, your brain will not allow you to do it. So simple little blisters will shut people down completely. So first of all, you've got to prevent them. Encourage people not to go open their brand new flip-flops. But prevent them. Once they develop, you don't mess with them unless you need to. If they're so big they're compromising things, then you can actually lance them or open them. Take a very sharp tool, a little razor blade, sharp pocket knife, and cut the side of it. You don't just split right down the middle of these things. Cut the side of it and leave the skin there. And then put some type of protective barrier over it, whether it's a blister bands or, I don't care if you want to use duct tape, it works okay. The downside of duct tape, it's going to pull everything off when you get off the bottom of the hill, including any surrounding tissue that was only a little inflamed. But if that's what it takes, duct tape them, I don't care. But I'm sorry, as far as I'm concerned, they're going to walk off that mountain. They've got themselves in that predicament as much as they can. I'm not that sympathetic. All right. Moleskin, duct tape, cloth tape, all kinds of things, package them well, and then tell them to get on their feet and hike out if they can. But when you're in the true wilderness setting, you're 4 or 5 days in, that'll be a disaster to your team. They can't move. What do you do? Literally cannot move. Ankle springs are not a huge issue, but you should learn the Ottawa ankle rules, which we're going to skip right now, but they're extremely effective, 98% sensitive. So if you meet the criteria, your ankle's not broken, you can just package it up, split it up, and walk out. So learn Ottawa ankle rules. Dislocation, yeah, those are fun. And what's that again? Is that not tenting? Yes, it is tenting. Don't miss that. That needs to be reduced before they ever get to me. Okay? And it's fun to put things back into place. And that comes into your wilderness medicine, more in-depth studies and classes. But dislocations, there's all kinds of fun ones to talk about. The treatment is, most of them icing the mobilization and just get them off the hill and get them reduced somewhere else. But some of them have to be reduced because of that kind of stuff right there. So it's a typical ankle dislocation. We see them all the time. It's pretty straightforward to put them back in. The patient may not like you, but it only takes about 2 seconds. But don't miss the tenting part, because if you call me on the phone and say, hey, I got this patient, there's no question, it's marked the annuate, it's tenting, I'm going to say, do you want to reduce it? You're thinking, I'm not licensed, and I don't like Robert DeBride Associates, and I said, I'll walk you through the process, and now it goes under my license, not you. And you pass it on to the patient, they say, yeah, I'll let you try it once, kind of thing. Others say, no, you don't touch me. Okay, that's fine, I'll worry about it. But if you can have somebody walk you through it, it's simple, straightforward procedure. You know, same thing. She's laying on her back, her ankle's rotating way around. You got to see the one I had the other day. That was awesome for the trampoline center. Wow, that was beautiful. It takes a lot to impress me anymore. So again, tenting. What's that one? What is this diagnosis? Dislocated what? No, not a knee. Okay, I wanted somebody to say that. What is this? A dislocated what? Patella, knee, cap. Okay? When you call on an ambulance or you call from Turk, tell me you got a knee dislocation, I will send a helicopter. And when I find out it's a kneecap dislocation, you are going to pay the $12,000 bill. Okay? Big difference. Big difference. We'll talk more about it in a second. Please.
On that ankle,
yep.
You know, us not being doctors, how would we necessarily know that there's not some broken bones in there?
You don't. I wouldn't know. Most likely it's not, but I wouldn't know.
I mean, you wouldn't want to be yanking on it.
Why not?
Pulling on it.
Why not? If you come to me with that ankle in the ER, the first thing I'm going to do is I'm going to reduce your ankle. Within a matter of probably 5 minutes, it's going to be put back into place. Now, I have the advantage of sedating you a little bit, but it has, and I don't get x-rays. X-rays come after the fact, because it doesn't make a hill of beans of difference whether it's broken, dislocated, or both. It must be reduced immediately. And even if it's busted into 1,000 pieces, I'm still going to reduce it. Yeah, so it doesn't change anything. Good question. We'll come back to the knee in a second. Jaw dislocations. Put your thumbs well padded. Wrap them up with some gauze. Put them on the backbone.